Just kidding. We're actually going live to YouTube. I'll share that link on Facebook. And yeah, Dr. Williams, I think we can get started, and I'll be able to do roll call here whenever you're ready.
All right, thanks, Travis. We'll go ahead and call the meeting to order and proceed with roll call.
Patty Bashaw. It looks like Patty's on. I do see Patty.
I am here.
Okay. Stand by. Dr. Bombard is not with us today. Dr. Broderick is unavailable. He had something going on. Dr. Brutus. Stand by here. Dr. Klaus. Dr. Klauser. Dr. Esper. Dr. Gerling.
Yep, I'm here. Can you hear me?
Yep, got you, Doug.
Okay, perfect. Hi.
Dr. Cardos. Dr. Katz.
Yeah, I'm here.
Dr. Morgan. Dr. Pond.
I'm here.
Mike. Dr. Richards. Dr. St. Jean.
Yeah, I'm here.
Hello. Tammy Trombley.
I'm here.
Tammy. Dr. Ventry. Dr. Viscardo. And Dr. Williams.
Yep.
Okay. That roll call has been completed.
All right, so we'll move on to the January minutes review and approval. And anybody have any concerns about the previous meeting's minutes? And anybody care to make a motion for approval?
I'll make a motion for approval.
Second.
All right. And vote.
Aye.
Aye. Okay, anybody opposed? All right. Previous January meeting minutes are approved. So we will move on to Agency ALS Operating Authority renewals and requests. Looks like the first one on the list is North Warren with Dr. Katz.
Yeah, no issues at all. Just typical renewal.
Okay. And Empire with Dr. Broderick.
Yes, Dr. Broderick was, he did reach out to me. He wasn't able to make it today. He has no issues or concerns. His signature indicates a forwarded motion to the body. But he also understands too, if you want to hold off until he can attend the next meeting. If you want to kick the can down the road, but he has no issues or concerns, and neither do we.
Okay. Anybody have any issues or concerns with Empire that we need to hold off for Dr. Broderick's input? No, not hearing any concerns. Okay. We'll move on to Cambridge Valley. I'm assuming that's in the same boat. So since Dr. Broderick's not here, does anybody have any issues or concerns with Cambridge Valley? Travis, they're all set with you? No issues with there?
Yep, yeah, correct. Same as Empire, no issues or concerns.
All right, so not hearing any concerns, we'll move on to Rouse's Point with Dr. Ventry. And Travis, Dr. Ventry was not able to make the meeting, correct?
Yeah, I didn't hear from him directly, but it doesn't appear that he's on.
Okay, so maybe we'll have to push that one to next meeting then.
Well, we do have the signature, and for the past few years, we've considered that as their
Okay.
endorsement and afforded motion. So I think probably Storm might be on and might be able to
I am.
speak then.
Okay.
I'm here. So there are really no issues with them. They have hired a person for their daytime coverage. They are working with Champlain in order to cover their issues. So I think we need to probably, if Dr. Ventry signed off on it, we can go ahead and go ahead and renew them.
Sounds good. Thank you. Salem with Dr. Gerling.
No issues with Salem.
Thank you. Fort Ann is one of my agencies, and currently no issues from my end. We'll move to Ticonderoga. Dr. Klaus. Anybody?
It's Patty with Essex County. Yeah, there's no issues. They've got coverage from the county and themselves and volunteers. So whether we're dropping like 200 calls or down to dropping like hardly anything, and I mean like hardly anything. So I would push it forward.
Great. Thank you so much. Morrisonville. I'm not sure who's representing Morrisonville.
So that would be me again. And they're an extremely active agency who does a very good job. They don't tend to drop calls. They tend to cover most of it and then fill in where the blanks are. They're also covering the state pod here as their medical team, as part of their medical team.
Great. Thank you. North Country Life Flight.
Dr. Viscardo, I don't believe is on.
Okay.
We do have, I think I saw Mary Jane Connor's name on here. Mary Jane, are you on? I don't know if you want to say anything on behalf of your agency, but we don't have any concerns, and we haven't talked to Dr. Viscardo about any concerns, but Mary
Yeah,
Jane.
I am on, Travis, thanks.
Sure.
It just text Bill to ask him to call in, but he hasn't yet, so
Okay.
I don't.
All right. No, anybody here with any concerns? Otherwise, we can continue. All right. So we'll move on to Fort Edward. Also, one of my agencies that started a BLS CPAP course. I did review their training, which looked sufficient, and I gave my blessing for them to initiate BLS CPAP. All right. Travis, do we need to make any formal motion to accept these renewals, or can we?
Yeah, if it were me, I think I would probably
Okay.
ask for a
Motion to
second
accept?
to all those forwarded motions and
Okay.
and do the ALS renewals in one batch and then do the CPAP separately.
Yeah. Okay, so not hearing any concerns. Would anybody like to make a motion to accept the ALS renewals?
I'll make a
I'll move
motion.
for that.
Yep,
Okay,
I'll second it. This is Doug.
thank you. All those in favor?
Aye.
Aye.
Yep.
Okay,
Aye.
anybody opposed? Okay, the ALS Operating Authority renewals are accepted. As for Fort Edward Rescue BLS CPAP, do I have a motion to accept?
Sure.
I'll make the motion.
Thank you.
I'll
Yeah.
second it.
Thank you. And all those in favor?
Aye.
Okay,
Aye.
any opposed? Okay, so the BLS CPAP is, operating authority is accepted. Looks like next on the agenda is the Department of Health Bureau of EMS field report. Is Mary here?
I saw Joe Farrell. I don't know if I saw Mary's name.
Okay.
I'm on.
Looks like they're both on. Yeah.
Nope. Wonderful. Anything to report from Bureau of EMS?
Well, this is Joe. Mostly what I have is operational, but I need to make sure we start working closely with the BLSFRs, especially the ones that are in the CME program, because they are beginning to reject submissions if you're not up to date. So it would behoove anybody that is a BLSFR, or actually anybody, but anybody that's a BLSFR should get updated information to me as soon as possible. If they have any questions, I can send them the required links to required applications. So, but they are rejecting CME applications if it is not current and up to date. So that's all I have. Most of what else I have is operational. Do you have any questions at the end of my report?
Mary, did you have anything to add or no?
No, I'm all set, Travis. Thank you.
You're welcome.
Sorry. Education reports. So start with Travis and Mountain Lakes.
I think you're muted, Travis.
My turn. Sorry about that. Yeah, so I was just going to say we have several courses running in the region. I'll keep it fairly short, but we have an AEMT course running in Granville, an EMT course that's just finishing up in Granville, an EMT course that we're working to get people finished up in Franklin County, which that group was severely kind of impacted, with COVID and different things, and dealing with lots of different issues. EMT course is running in Essex County, and courses that we're looking at, we're working on some additional stuff in Washington County. Our summer course in Queensbury is full. We shut off registration a week or two ago. Just a massive response to that. So we shut it off at 30, and we already have 5 or 6 on a waiting list in case openings pop up. So that's encouraging. It's always a big class, but we do a couple of these summer classes. Sometimes Scott in Franklin County does these, and we get a big response, especially from the college age students. So So that's good. We have a couple other, I guess, education related things. We've been working with some partners in the this region and Remo to produce some leadership, EMS leadership content over the past 2 or 3 years. And our latest project is a podcast, which also kind of doubles as a uh, video session that we stream to Facebook when we record the podcast. And it's called the EMS Board of Directors podcast. And it's we're kind of treating it as a Board of Directors 101 sort of series where we bring on people from strong agencies who are running strong agencies and talk about executive level nonprofit type of leadership and roles and responsibilities and finance issues and things like that. All stuff that hits home for really all of the nonprofit EMS agencies, but especially those ones who might be struggling in the more rural areas, don't have a lot of access to funding and things like that. So a lot of good content there. It's obviously open to anybody. There's a link on the Mountain Lakes website. You can go and you can listen to episodes there. You can download through Apple or Google Podcast platform. And then the other education thing I was going to mention is the initial assessment conference, which takes place next week in Glens Falls. We've got a ton of really exciting hands-on opportunities. We're getting people back in the classroom and getting their hands on things for the first time in over a year, which is, hugely important to their practice as a clinician, especially in the lower volume areas where they don't see as much or do as much. So getting people, from behind the screen and getting them in a classroom and doing it safely with the vaccinations and some testing that we're doing on site and all those different things. It's going to be really exciting. So if any of the REMAC members are close to Glens Falls next week and you want to swing by and check out, a course or to see what it's all about, feel free to do so. That is the end of my education report.
Thanks. Thanks, Travis. Let's see. E-Town paramedic.
Bruce Berry, did you make it on? I don't see Bruce on, so we'll probably have to skip that one.
Okay. We'll push that to next meeting. Alice Hyde.
Scott Duncan from Alside. No updates or changes. They're still running the daytime course and intend to offer a fall course. Thanks.
Thank you. Clinton County. Dr. Bombard's unavailable.
So in Clinton County, we are just finishing our AMT course and our basic from the spring. We are going to do a very aggressive summer course. We're going to run 3 days a week. We're going to run 3 6-hour days and a half day on Friday, and finish the course in like 6 weeks. We've warned everybody that this is going to be a difficult course because we're not running it throughout the whole summer. So I'm not sure what our registration is at this point or whether it's even going to run. And then if this one doesn't run, then we will pick up in the fall with our regular basic and spring course. That's where we are. And we're hoping that Travis is still working on our CLI course for up here for sometime this summer. Right, Travis?
Yeah, the state is still not allowing us to schedule CLI courses. We're still waiting on the curriculum, and I believe they had a key employee that's having some medical issues and she's out right now. So I think it might be delayed a little bit longer, but that's a good reminder. Maybe I'll email somebody right now and see what their status is, or if Mary or Joe, you happen to know, please chime in, but I'll find out and see if we can schedule something.
I think that everybody, I think we're all looking for instructors. And so I think it's helpful if we can just keep reaching out. I know we've been using Mary to go through to get some of that. We had a CLI that just finished, and we have a CIC that just finished their internship. We have another CIC that's going to intern either this summer or in the fall. So we've been trying to go through Mary. I'm picking on Mary. Poor Mary gets picked on by us all the time, so that we can get these people finished up and get them going. So thanks, Mary, for all your help.
Great. Thank you. North Country, Dr. Katz. Oh, no, sorry. My apologies. Clinton Community. Oh, we just did that. Okay, sorry. Lost my spot. So thank you for the reports. We'll do the QA, QI reports. From Glens Falls, Dr. Gerling and I, we've been doing some local hospital stuff, trying to improve some of the flow through the hospital, and working with some of the staff. We, in response to the, I'm not sure if everybody else experienced this, we had a few months ago the issue with cocaine being laced with fentanyl, which caused over a few weeks a number of overdoses and deaths, stretching from the capital region and all the way out to up here and out west, I think, towards Utica. So we worked with some of our community partners and harm reduction partners to create a brochure that we can hand out to patients both in the hospital and in the pre-hospital setting, that lists just resources that they can use for substance and mental health care. The thinking was that a lot of times we can treat these patients pre-hospitally, reverse them with Narcan, or help them with their issues, and they often either don't come to the hospital, and most of the time don't even want to hear about us talking to them about resources. So if we can just give them something physical that they can take home and maybe look at a later time when they're more accepting of the situation, then they'll have something there that lists a lot of resources they can use. So we worked with some local partners and hospital resources and got this pamphlet put together. So we'll be giving that to some of our agencies to give to any patients that they come in contact with that may benefit from those resources. So that was kind of one of the big things that we've been doing lately. No other real QA problems in the area. Dr. Gerling, do you have anything to add?
No, Tom, you covered it nicely. Thanks.
Okay. All right. So that's it from our group. E-Town.
Hey, it's Aaron. So I took over doing the QA coordinator from Mike Weller at E-Town. And we spent the last quarter diving into a big pediatric study. They came out with some good topics and did a big case review on an amputation case that was up on Whiteface over the winter. And spent probably close to 4 or 5 hours on the phone with IPCR to set up doing direct feedback with agencies that transport to E-Town and Thai, and working out a deal with AMC to also give some patient feedback for the people that are in our catchment to go to those hospitals.
Great. Sounds exciting. Thank you for that. Alice Hyde.
The Alice Hyde group has met a couple of times, and I see Dr. St. Jean is on, and we are getting back on track and starting to have meetings. I don't know if Dr. St. Jean would like to comment.
No real comment. I mean, we just resumed a couple 3 months ago, and we just had a meeting, I think, a few weeks ago. So we're going to make sure we're having a regular basis and and make sure we're keeping an eye on all the different issues that arises.
Great. Thank you so much. Clinton County.
So we, as we have all our agencies coming online with EPCRs now, we started looking at the state data, and Zach helped sort that data for us and send us some of it. So we're going to use that as our primary focus, is to be able to pull data in and then to be able to look at how well we're doing across the state guidelines and see if we can improve some of our numbers. So that's where we're kind of heading with ours.
What numbers are you looking at?
So we looked at aspirin usage and we looked at blood sugars as the two of the easiest ones to kind of see where we measured up to what the state wants us to be at and what we're actually doing. Which was it was interesting. We didn't quite get the data to match up the way I wanted it to. So we need to take an in-depth study of really what we're looking at and try and sort it out. Because that's really the biggest problem, is knowing how to read the data that they're actually feeding us. So it'll be interesting once we're able to do that.
Yeah, from personal experience, the data that comes from the state bridge isn't the easiest to work with. So
yes, it is not.
So I feel you there. Okay, now we'll do North Country with Dr. Katz.
Not much to report. We continue to meet monthly, just doing case-based education. Interesting, challenging cases, but carrying on, no issues.
Cool. Thank you. All right, data and informatics with Zach.
Okay, I think I'm on. Took me a second to double unmute. So I ran a bunch of reports for 2020 data for the year. I did it as region reports, and then I also broke it down, the same report just by county, so we can kind of evaluate it by counties and also by the region. And I also ran the same report for 2021 data, January to March, so the first quarter. And again, I did it by the region and by the counties, broken up. I sent them to Travis late, so they weren't in the meeting materials, but I can make sure that we send them out to everybody. Again, really, the biggest thing is making sure, we're selecting the right options for things. There was one county that had over 200 patients dead on scene without transport, which just seems extremely high. Even if that was our region average, that seems extremely high. So I think, the more we can pull reports and I can get reports to agencies, we can kind of improve some of this data. One thing I noticed running the reports today was, for example, like Warren County, most of their agencies pick oxygen. It's like 99% inhalation gas or whatever they call it. Whereas a lot of Clinton County and Franklin County picked just the basic oxygen option. So I think we're going to have some education coming out hopefully soon, trying to get people to be picking some of the same options for items. And that'll help with some of our numbers and stuff. Again, a big one that we have is our destinations. A lot of agencies have changed some of the destination names, so that way they come up on the top of their list, which is totally fine. But when I run a report for the destination name, I get 5 different names for the same hospital. So then I have to add up results and stuff. Where if it's mapped behind the scenes, if I run the report by the destination number, all that information is in there by the number. So, a couple different little things here, like this one that Travis has up, oxygen is the very first option. But then if you look like the 10th one down, oxygen, 99% gas for inhalation. So, there's a couple different options that agencies are using for what would, I assume, would be the same medication administration. So some of it is kind of just behind the scenes mapping, probably, you know, does this certain software vendor map oxygen to this one option versus the other option, which I have the feeling is kind of most of our issues. But I'll send out those reports to you, everybody, so you guys can take a look through. Again, I have them by region and by county, and we can, you know, kind of work from there. You know, even just this one here, there's the first two options are your 12 leads, you know, which probably could be combined under the same treatment provided. So, you know, some of this will be, you know, just education for agencies. Some of it will be education for actual software providers and vendors, making sure that they're, you know, not mapping things the wrong way behind the scenes. But these are fairly easy reports here. These ambulance run data reports. I ran some for Storm, as she mentioned. So if you guys have anything you're looking at, let me know and I can see what we can do for you. You know, so that one that Travis has there, that must be Washington County. And so again, you know, the reports that I'm running, they're only for electronic agencies. So it doesn't include any paper PCRs. None of those agencies are included. With agencies transitioning to the new state software or to actual specific software vendors, we're going to be able to start getting a lot more data and more complete data versus, you know, just the electronic agencies. Even the paper PCR agencies will be able to pull up certain information from their data fields as well. I think the next thing on there was scheduling wise. So we've had 5, let's see, 11, 12, 13. We've had about 16, 17 agencies already that have switched over to either the state's free software or have gone with one of like the fee for use softwares. So we're doing really well. Clayton County is probably the biggest one that has been done so far. And, you know, we did a Zoom meeting up there for their advisory board. We also went up there and did an in-person meeting for a bunch of the BLS FR agencies. You know, so if you guys are looking at switching or want to hold a Zoom meeting or an in-person meeting, let me know. You know, I'm flexible. We can do something in the evening if that works for your agency. But the biggest thing is before the end of June, July, basically the beginning of July, all the agencies that are documenting must be switching to either the paper PCR portal or a full electronic option. And that's going to be, after then, we'll really be able to get some good data from the reports from Department of Health, more comprehensive data.
Great. All right. Thanks, Zach. Collaborative protocols update. Travis, got any information for us?
Not a whole lot. We did get notification that the state has been able to contract with a vendor to build out an app. The protocol app that we have, years ago, we got it first fired up with a couple of other regions, and you know, since that time, over the years, it's you know, more and more regions jumped on board the protocols, and it's really for the most part, a statewide app. And the state took on a project to contract with a vendor and to create a protocol app. So we're going to get more information on that soon. It's not quite ready, but that'll be coming out. And I think the good thing about that is it'll reduce the cost burden on the regions when producing the app. We got to see what components are available in it, but should be able to access protocols and current policy statements and things like that. So that'll be handy. Other than that, I'll just remind people there is a link on the website. If you do have suggestions for current protocols, whether it be revisions, new protocols. If you have an idea, if you want the group of physicians to look at a certain medication, or if you feel like something should change, there's a link there that you can click on and submit those suggestions, and they do get reviewed. We've had several great suggestions from the region, and those will get pushed out to Dr. Bombard and the rest of the docs who work on this stuff statewide. So if you have something for protocols, feel free to use that link and um, do your submission. But other than that, Doc, I've got nothing on protocols.
Okay, thanks, Travis. CMAC report. Is anybody able to step in for Dr. Bombard and give us any reports on the CMAC? If not, we will push that off until next meeting. Travis, what's next on the agenda? I think your screen. Let's see. Looks like old business. COVID operations and issues.
Yeah, sorry about that. I was muted again. Yep, that's all I had under old business, and there's nothing really necessarily to report, except that we continue to support as much as we can and encourage people to continue mask use and taking things seriously, even if they're vaccinated, especially in the back of the ambulance, N95 and iPro use and gown use with either a COVID patient, suspected COVID patient, or if they're flowing oxygen or doing airway procedures. Seeing a lot of providers being super laxed, and that's not good. And I have gotten some questions regarding the policy about being masked when people can't distance in station, or being masked in the ambulance when they're riding in the cab together. And it's a good question, because people are saying, well, if two people are working together and they're vaccinated, why do they have to be masked in the ambulance? So my response is, got to kind of wait for some of this stuff to come out from the CDC, which is what the state is going to probably base most of their directives from. So until any directives that have come out have changed, or there's an update released, then it's still a requirement. So, and then I would just say, be careful if you're allowing your people to do something different, because you could certainly still be cited or fined by the state if they find something different. So I would just say, tell your people to be patient. I'm sure updates are coming soon, hopefully. So that's all I've got COVID related.
Yeah, I just want to add on that note, Dr. Gerling, Dr. Cass can attest to this as well. We're seeing an uptick in cases again in the hospital. I'm sure it's the same for a lot of the region. It's presumably the variants, the British, the Brazil, South African variants are making their way through. So, we are seeing our numbers creep up again. And I had a case the other day where a patient came in and had 3 negative COVID swabs in the last 2 weeks. And then the one we did for admission to the hospital came back positive. And he'd had a negative rapid COVID swab at urgent care just before he came in. So, it's still out there, and it's easy to get fooled by some of these rapid swabs. So, we should all be taking our precautions seriously.
Yeah, Bryce just put a handy link there in the chat box. The CDC has released allowances of non-social distancing, gathering of vaccinated people. Yep, and I think it's just waiting for the state to update their policies and directives. But every time we get an inquiry, we pass that along to the bureau, and in hopes that they take it up the ladder.
Great. Okay. Any other old business to discuss? Okay. Not hearing any additional old business. We'll move on to new business. Destination decisions. I'm not quite sure what this issue is.
I think this was a Tiffany topic, mostly may have had something to do with Wilmington Whiteface because of the 3 different locations we can transport to.
Gotcha. Okay.
Yeah.
So this has been, I think it's
Oh, yeah.
still, even without Tiff here, I think we should have some discussion, because in our QI group, we've had some cases where, patient preference, may be reasonable from a pure patient care standpoint, but given the region we serve, I personally have a hard time taking an ambulance out of service for an extra 45 minutes or an hour, or sometimes 2 hours, depending if there's a closer appropriate facility. So, the way the DOH regs are written versus, how we choose to operate as a REMAC don't necessarily have to be, word for word the same. And I think we can offer some guidance that, especially because most of our catchment here is rural, underserved, there's not a ton of close by mutual aid. We really need to be more aggressive about closest appropriate as opposed to patient preference, from the standpoint of keeping our rigs in service.
Yeah, I think that's a good point, Ben. The big caveat I would add to that is that we need to take into account where patients get their primary care. So, if there's a patient who, their cardiologist and, their GI doc are all in, Rutland, then that's probably the most appropriate hospital for them, rather than necessarily the closest being the most appropriate. So, I think there is some area for, deeper consideration rather than just the closest, but I agree.
When again, I'm saying closest appropriate. If someone just had surgery, it makes more sense to go to the hospital where they had surgery, unless they're unstable and need to be resuscitated. But at the same time, I think, luckily it's not every day, but there's often times where we lose an ambulance for 2 hours, and mutual aid's 20 or 30 minutes away. It's not ideal.
Yeah, no, I totally get that.
So if I may, we work in kind of a unique system: Lake Placid, Saranac Lake, Keene Valley, Wilmington, Osceola Forks transport to the Adirondack Medical Center. And they have 2 sites. They have a Lake Placid site that's open from 8 a.m. to 8 p.m. that doesn't have CAT scan, has basic x-rays and labs. And then there's a site that's 15 to 20 minutes further that is the Saranac Lake site that has CAT scan surgical capability inpatient. And I personally have run into issues of getting negative feedback from the hospitals for bypassing one or the other. And they current pushes for the providers in the field to call for medical direction to bypass one or the other for a more appropriate destination, as opposed to leaving it to provider discretion as our protocols dictate. For example, I had a patient with chest pain, and it was 45 minutes before the Lake Placid site closes. I know you have to have a 4-hour repeat troponin. It's not an appropriate clinical decision to take them to Lake Placid, even though they can pull the troponin and run the labs there. In 45 minutes, they're going to be put back in the ambulance and transported to Saranac Lake. So I transported directly to Saranac Lake, and I received negative feedback about that because the lab is in Lake Placid, but the surrounding circumstances, I don't believe that was the best patient care scenario. And that's just one example of many.
Yeah, and this was originally put on the agenda after talking. Bruce kind of hit the nail on the head, and Bryce is talking about that same area, in particular the Lake Placid facility versus the Adirondack facility versus going to some sort of trauma center. There was some incidents where those decisions kind of were questioned, and I talked to Dr. Pond and Dr. Bombard and some other people, and thought it was worthwhile putting it on the agenda to kind of see. The REMAC does have the authority to address some of these issues about what can go where based on capabilities, certain destinations, and I think to some extent, and especially just hearing it from Bryce, is that there's sometimes pressure from certain facilities to go to those facilities based on their own internal health network system and different things like that. And it doesn't mean it's always the right decision. I do think it's reasonable that this body could look at some of those more complicated areas or issues and kind of weigh in, in kind of partnership with that individual medical director.
I'm gonna just chime in here for a minute because I'm probably got the only institutional memory, since I think that been on here longer than maybe anybody that's still on. Although I'm not sure. This issue's been going on and on and on for years. The last few years, it's risen its head multiple times. And my suggestion is always to have Adirondack Medical Center ED director and the facility to be involved in the decision, and that not Mix does have the ability to make this decision. So now Chip Esper sits on REMAC, and it might make sense to actually have this discussion when he's available, or as I've suggested, have the discussion Travis sort this out, because they've got to decide, and the medical control has to be consistent, and you can't. When this just came up, you just can't second guess. I mean, we had one this winter that got sent there. Why did it end up there? And it shouldn't have been there. And of course, the patient changed, and lots of other things were involved. But you got to have a real reason to call a place an ER that doesn't have. In fact, I'm not even sure they call it an ER anymore, but that doesn't have CT or MR or any backup whatsoever after hours. Correct me if I'm wrong. I don't think there's a department open other than that's not an ED. There's probably 4 people in the hospital. I don't even know how you could run a code without EMS being there. So that's my suggestion, that you need to have this conversation not with REMAC, at least to start, but with the involved facility.
Okay. Tammy, you have your hand up.
Yeah, it took me a while to find the hand, but I just want to caution that we follow really best practice and national standards, and state recommendations and regulations in regards to closest, most appropriate facility. I think that from the trauma center perspective, there's a big push from the DOH to have ambulance crews transport patients to appropriate level trauma centers or trauma centers in general over non-trauma centers. And I think that we are very rural, and we need to be super careful about where our patients end up in regards to what types of care, as was just stated about which facility can provide what, and making sure that we don't bring patients to places that can't care for them in the context of time, especially speaking, of course, from trauma.
I don't think we should just get stuck on trauma though, because that comes up when the case Bryce has brought up doesn't involve trauma, but
right,
has huge ramifications with other things too.
And I mean, it's easy if we decide to go to CVPH, which we as providers do on a regular basis, especially STEMIs. Anything large trauma, we do typically try to go to CVPH or call HEMS if needed. But it's the things of like, this patient has had abdominal pain for 3 days and is going to need a CAT scan, and we're being told to bring them to a facility that doesn't have CAT scan. And then an hour and a half later, we're putting them back in the ambulance and transporting them again. And the patient gets billed if they don't get admitted. They get billed for the transport. And it's just, I don't think it's ideal patient care. And I don't think it's ideal like financial practices that's in the interest of our patients.
Again, I'm going to say, having this discussion without the facility does not make any sense.
Well, and we all know that we have limited interfacility transport availability, right? I mean, it takes hours sometimes to get patients out of our hospitals that need to get to higher levels of care. And that only hurts the patient. But inappropriate transfers or transfers that were avoidable can reduce the strain on that system that's already at its peak.
And I do think it's a conversation, Dr. Ponitz. I mean, it's a great point about Dr. Esper, that facility not being on this call, but I do think it's a conversation for the entire region. I think it's a conversation for all the networks and all the hospitals and all the agencies, because as a provider here, I've got a pretty darn good idea of Glens Falls Hospital's capabilities. But do all providers understand what the capabilities are so they can make the appropriate decisions or call med control and have a competent conversation with a physician before making a transport decision? We're putting providers in a really tough position, as Bryce mentioned, with that decision in that particular case about deciding where to go. Well, what are we basing that on? Are we basing it on their actual true honest capabilities and what's right for the patient? Are we basing it on standards and things, as Tammy said? Or are we basing it on that internal facilities or networks desires? And I certainly wouldn't want to accuse any of them of putting money before patients or anything like that. But we do need to ensure that those decisions are genuine and they're based on the correct things and not the wrong things. So I think it's a great conversation for the entire region, because the entire region is rural. We're not that different networks, different hospitals, different distances in some cases, but we're all in the same boat.
Travis, I think the other thing you need to also take into consideration when the discussion happens is the availability of ALS, because there are a lot of agencies running around with BLS and may or may not be able to get to an ALS provider. So I think it's more than just the right hospital also.
Good point.
Hi, it's Aaron. I'd like to kind of chime in on that too. Is with Essex County as a whole, kind of looking at it from where it was back then of always going to the specific community hospitals, there's been a big change to where, adding to the ALS there and adding to the coverage that we've been able to make that push to, if this person has had new onset chest pain that has all these problems, we're able to now go to the appropriate place like Glens Falls or up to Plattsburgh. And then there's kind of that backfill coverage through the arrangements of the coverage that we set forth. But I could definitely speak to that Lake Placid experience too, where you get told to go to the little 4-bed ER, and then it's just a domino effect from there.
Is this deserving of some sort of committee or work group to kind of examine this further? Instead of kicking the can to the next meeting and then having the same discussion and not getting anything done, maybe between some of the services and our air medical colleagues and the hospitals, maybe we can examine this further. I don't know how to move forward necessarily, but that's just one thought.
I would definitely be on helping out from the ECHQA perspective of looking at cases and coming up with some legitimate data to support making better decisions. If that is kind of the way to go with that.
So Travis, I guess my question is that what do you expect to get out of, are we going to make recommendations as to where people are going to take people? Or is that not really something that we are going to have that kind of control over? Because I think that really becomes the dilemma. So you can, we could kick this around forever, but the question is how much can we actually accomplish, and what is our mandate to be able to do that?
That's a great question. And actually the REMAC does have the authority to examine and put forth guidance or policy on transport decisions and destinations.
Well, Travis, I think that, I don't think the REMAC's going to be able to tell any agency where to take each individual patient. But what I think we can do is create a framework for decision making. It's every transport is going to be patient dependent, and it's going to depend on a lot of factors such as is the closest hospital even open, right? I think what Bryce was talking about when he made the decision about bypassing a hospital because it was close to closing hours is a very appropriate decision, and it's dependent on a lot of factors. So, if we do create a group, I think the goal is to give them a framework to make a decision in and give them the capacity to make a clinical decision, because you touched on it earlier, hospitals are run as profit institutions now, and it may not be in the patient's best medical decision or it may not be the best option for the patient to go to the closest facility while these institutions are pulling for those patients, because I think we have a number of factors impacting the decision, the hospital's decisions for these patients.
Well, I think you're right. Ultimately there has to be in every situation, whether it's this or something else. Yeah, you can, having things in kind of black and white is all good, but I like kind of what you're saying about also arming our clinicians on the street with the information that they need. What are the capabilities? What are the hours of facilities? This is kind of, like you said, the general framework, but also with the message that we trust you. Mm-hmm. We trust you to make that decision. Or we trust you to, when you're in doubt, to pick up the phone and call med control and consult with a physician. But I do kind of sense that there's a lot of confusion in maybe that one particular area in the Tri-Lakes area, as to where to send people, and if they make a decision, that they are being ridiculed for that decision. And maybe that ridicule is not based on anything other than what you had mentioned previously. So, again, do we need to come up with this big binder of rules? But no, I think, as you mentioned, this general framework, arming them with information. What are the true capabilities of these facilities? Do they have CT? Do they have orthopedics? Do they have whatever it is? Because that's not always obvious, especially if they're functioning in a mutual aid capacity in a different county. And getting that information out there in supporting them, the providers, once we give them that information.
And Travis and Dr. Williams as well. Like, I think at least in the Tri-Lakes area is an intervention on the pressure placed on clinicians and providers by the healthcare system. This, like, mother, may I take this patient to the right hospital framework that's in place now is often proved detrimental to patient care, I think, which is why I think it's such an important conversation. But just
Hello?
Where clinicians we're trusted under our medical directors to make these decisions, so allow us to make the decisions instead of the framework that exists now.
Yeah, so I think, Travis, to your point, I think there should be some sort of committee or group that kind of considers this question and creates an outline for our providers to make the decisions that we are already allowing them to make, and provides them the backup to support their decisions so that they can go to these hospitals and show them that they have the support of Mountain Lakes to bypass when they feel it's clinically indicated.
Yeah, and to not bypass, right? Because if you have that head injury patient that's combative and you need help with sedation and airway control, that it's okay to go to the community hospital instead of bypassing or flying that patient to Burlington or whatever, because you need to get the situation under control. So it goes both ways, and I think they need that flexibility. I think they need the information, and they need the support to make those decisions. I don't know. We need to trust our people out there, and
Right.
and trust the docs on the end of the phone when they consult.
One of the providers just texted me saying information on what the hospitals do provide, because it does change from time to time. They get new technology and stuff. So it really could be a plan of provider education, maybe docs talking to management at the hospitals saying, hey, they shouldn't be getting crap for this stuff. It could be like a plan and a pronged attack.
Yeah, no, and it's vital that we understand what each facility has to offer, because you're right, it does change. And even speaking from Glens Falls' perspective, there's times when we lose coverage for certain specialties and other times when we gain it. So it's always changing, but we need to know what each facility has to offer, because taking a patient with a STEMI to the closest hospital, if they don't have interventionalists or if they can't give TPA or whatever, is inappropriate. So I think that's got to be part of the group. Part of the group's mission is to kind of delineate the capabilities of each facility and give the providers the information and ability to decide on their own which place is more appropriate for their patient.
Yeah, and we're talking about a resource document, right? And just giving them that information and the right information. I don't know. I don't know who makes up that committee, but I think it's worth looking at and exploring between now and the July meeting.
Yeah. Well, it sounds like Aaron already volunteered himself for part of that group, so
There it is.
looks
Look
like
at
we can start there.
Yeah, no problem.
Yes, I'd be very interested in that group as well.
Okay,
Dr. Bombard would like to be on that group also.
great. Well, I think that's a great start. And why don't we start branching out from there? And I don't know who wants to take point on this and start arranging for members in this group. And then, you know, I don't know if we'll be able to get any updates by our next meeting in July, but, you know, going forward, it'd be great to hear from the members of this group to try to, you know, see what we can come up with and to continue the discussion.
Yeah, I'll get together with Bryce, Aaron, and Dr. Bombard, and we'll kind of branch out from there. I don't know if Dr. Pond, are you still on? Do you have any interest in if I can get Dr. Esper and I'd really kind of, I don't want to solely focus on the Tri-Lakes area, but clearly we need to address this. So
I'm not going to spend a huge amount of time addressing what I've addressed for the last decade over and over and over. Honestly, whatever Mountain Lakes decides to do, I'll endorse. But you got to put the hospital in the room.
understood. Okay.
So you can let me know when you have the meeting, and if it works out, great, or I'll give you my opinion, and I can look at the document. But honestly, I've spent way too many hours on this issue. As you know, Travis, I've been writing emails about it for the last 2 solid years.
I'll be in touch with you, Mike, and I'll keep you posted.
Okay. All right. So any last public comments or questions?
Just gonna check YouTube quick. I'm not seeing anything. I will say our next meeting, we'll see how things are going. I don't think we have to rule out something in person as of this moment, but our next meeting is July 19th. So it's actually kind of 1 week earlier than our typical meeting date. So Monday the 19th at 2 p.m.
All right. So with no further comments, we'll make a motion to adjourn.
Motion to adjourn.
Okay. Second.
Yep, second, Doug, and in favor.
All right. Yeah. All those in favor?
In favor.
All right. Anybody opposed? All right. Meeting is adjourned.